that it is not an easy job for you guys to be in this class. Like as I say, 3 times a week, like every day you have to spend 2 hours for the lecture, and that will be followed by homeworks. On top of that, you may have another class and your work, your family. So I know it is pretty harsh. So now we will take a break and just try to memorize or try to digest what we have talked about. And please always check on the Canvas website. Like if you go to modules, so I'm going to modules. So then if you go to we are now in unit, where is it? Unit 2, like we are doing, what have we done for this unit? Skeletal muscle tissue. And you have to do the homework. You have done skeleton and endocrine system homework, the heart, first and second lectures, and homeworks for the heart, anatomy of the blood vessels, lecture and the homework, and we have done blood as well. So it is quite a lot, you guys have covered quite a lot already. On top of that, the very first lectures, they are like introduction to anatomy, tissue, skin, bone, and skeletal tissue, and the joints. So how many lectures have we covered? 1, 2, 3, 4, 5, 6, 7, 8 and 9, 10, 11. So we have spent about 1 month for this class, and we have covered 10 lectures, and you have done 1 exam already, you have done many homeworks already. So which I think is pretty good. May just try to pull yourself together. Let's go to the skeletal muscle tissue. So yes, a lot of muscles. We were talking about a lot of muscles. And these are the pioneers, Draper and Hodges, Gene Hudson and Huxley. We can forget about them already. 3 different types of muscles: smooth muscle, skeletal muscle, and cardiac muscle. Smooth muscle, spindle shape, more like, smaller, with the central nucleus. Cardiac muscle, which is a striated muscle. Skeletal muscle, which is a striated muscle. But the difference is cardiac muscle, they are smaller. The skeletal muscle is bigger, larger, more longitudinal. And the cardiac muscle, they do branch and they do join. They do join, they do branch. So that's the difference. And you can see the intercalated disc here for the cardiac muscles. So cardiac muscle, there are only 4 types of tissue in our body. Number 1 is epithelial tissue. Number 2, connective tissue. Number 3, muscle. And number 4, blood. So that's our nervous tissue. So only 4 types of tissue in our body: epithelial tissue, connective tissue, muscle tissue, and nervous tissue. So this is one form of body tissue. And you can see the difference now between the skeletal and cardiac, because skeletal muscles are much bigger and thicker and more longitudinal. These are smaller, they do branch, they do join. Smooth muscle is just a little spindle cell, smaller, much smaller than the cardiac or skeletal, and they do not have striations. So this is the skeletal muscle tissue. Why is that? Because they are very linear, they are very large, and they call striation, striated muscle. And this is what we talk about. It is pretty difficult information to absorb. But if you think about that, we have in between two Z lines, we have actin and myosin. And don't forget the bicep muscle we are seeing, like which you can see with our naked eye. Bicep muscle, it is an organ, yeah? So bicep muscle plus the humerus bone, it will create the upper limb musculoskeletal system. And we have talked about heart and blood vessels already. The heart is an organ. The blood vessels, they are organs. Combination of heart and blood vessel, they create cardiovascular system. And type of muscles is too frequent for you guys now. It's a bit boring. Skeletal muscle, cardiac muscle, and smooth muscle. We haven't talked about smooth muscle yet, but we have talked about skeletal muscle and cardiac muscles already. Don't forget these pictures repeated again and again, but they will come in a slightly different way. But actually, you know, it is what we have to differentiate is it is striated or is it smooth? If it is striated, do they branch? Are they big? Skeletal or cardiac muscle? That's all. So which is not a bad thing. Characteristics of skeletal muscles. I want you to remember that. I believe you guys know this already, because this is really important in our clinical practice. Contractility. So if you squeeze, the muscle will contract. If you put an electrode on top of a muscle, the muscle will contract. Excitability, you can excite it with the chemical or the electrode. Elasticity, so it can be stretchable and go back to the normal position. And extendability, you can stretch it and it will go back to normal. Stretch it. So why are these properties important? Because if we want to check if a muscle is still viable or not, like when we are doing debridement of a wound, which is very dirty wound, so we want to remove as much dirty wound as possible, but at the same time we want to leave as big muscle as possible. So clean wound, which is viable, because there is no point leaving a dead muscle. So we need to check whether that muscle is still viable or not. And these are the characteristics we need to check. And you have seen deltoid muscle already. So deltoid is on our shoulder and chest muscle, the pectoralis major muscle already. And if we remove this pectoralis major, we will see the pectoralis minor muscle. And on the back, so this at the lower part, big flat sheet of muscle, which is called latissimus dorsi. Dorsi means in the back, latissimus means large, big muscle in the back. And the upper triangular muscle up here in the back, it is the trapezius, yeah, trapezius and the latissimus dorsi. But if we look under the microscope and every skeletal muscle, you are going to see this in between 2Z. So try to identify 2Z and M line. So you might want to say, hey, this can be Z and this can be Z. In between two Z, this is the M line. Well, because in the center of the sarcomere, you have the overlap between the actin and myosin. Therefore, it is much darker in the center. So therefore, this must be Z, this must be Z, and this must be M. M for middle, Z is the end of a sarcomere. So this is a sarcomere. Hierarchy. So it is difficult to remember. I appreciate that. But for the sake of exam or the anatomy class, I want you to remember it. And after that, forget about that. At least you have a confidence that you know that already. Because if you feel like, hey, it's too much and it's too difficult and too detailed, and I'm not going to bother about that, then you will never remember that. Because this is something we will have to see when you come to higher education in anatomy. This will come back again. So this is really important. So each and every coach of a tray, we have to take it as sarcomere. Sarcomere is a segment between two Z line, and in the center we have M for middle. So if we arrange every sarcomere in a longitudinal direction, and sarcomere, continuous longitudinal arrangement. That continuous arrangement is called myofibril. Braille for rail, myofibril. And if we arrange myofibrils, one myofibril, another myofibril, another myofibril, if we have another myofibril here, if we just collect all the myofibrils together, and you wrap with the sarcolemma, and you wrap with the endoplasmic reticulum, then it will become Marcel fiber, BER fiber. Yeah, that Marcel fiber is equivalent to a cell. So of course, inside the myofibrils, we do have myofilaments, which are actin and myosin and T10 proteins. So if you collect Marcel fibers, you wrap with the perimycium, around mycium, and you will get the Marcel fascicle. So fascicle is enclosed by perimycium, and if you collect all the Marcel fascicle covered with the epimycium, then we will have the Marcel, which we can see with our naked eyes. So yes, that's the hierarchy. This is the way I try to remember Sacramento, sarcomere, ray, myofibril, Marcel fiber, fascicle, and then Marcel fiber, the Marcel itself. So like every time, for this class, you have done homework. And for the exam, after the end of these lectures, then you might want to flip a little bit, and that's it. Forget about again. Because like in medicine, there are a few things we need to just try to remember. That's a bit sad to say, because no good reason. But that's life, in life, we have to swallow many different things. Like, what is this? This is a phone. Hey, how can you remember this is a phone? There is no reason, you have to say, if you say something phone, means you relate to this, cellular. So cellular, phone, mean a cat, mean what is the relationship between CAT and a real cat? There is no relationship, but we try to connect together, because we have been doing this since we are very young, and that's stuck in our memory. The same thing like in medicine or in nursing or in many medical related specialties, there are a few things you have to grab it because these are the nomenclature, and that is the basic information. On that basic information, you will have to relate for the higher education and learning. So yeah, big muscle. So this is a femur. The muscle, if you look about that, endomysium. So the fibers inside the endomysium will be myofibrils, isn't it? Perimysium. Where is perimysium? Here. Perimysium will wrap around the muscle fascicle, and epimysium will be wrapping around the muscle. Where is it? Muscle fascicles, endomysium. Endomysium, where is endomysium? Endomysium is here, muscle fiber. So epimysium is the big structure, collecting the whole muscle fascicle. With epimysium will be the whole muscle fascicles. So I mean, it's a bit daunting. Just grab it for a few seconds and just forget about that. And function of a muscle, I cannot make any question out of this function of a muscle, because you all know that already. I mean, it is nothing rocket science. And terminology, like, don't forget osteon, neurons, and sarcomere. So these are the basic units. Osteon, the basic unit of the bone. Neuron, the basic unit of the nervous structure. And sarcomere, the basic unit of muscle, functional unit, basic. Cytoplasm is equivalent to, in muscle, we call sarcoplasm. Cytoplasmic membrane, we will call sarcolemma. So the lemma and cytoplasmic membrane is now very different. Like endoplasmic reticulum in the cell will be sarcoplasmic reticulum. So this is pretty similar. Muscle composite tissue. Muscle is sarcomere muscles, and which is covered with the endomysium, perimysium, and epimysium, which are the connective tissue. The origin and insertion. So like a muscle, we start from a bone, become muscle, and then become the tendon again. Where is it? So this is a very good diagram. So a muscle, big fat thick muscle, start as a tendon, originate from the bone, tendon, and all the muscle fibers. So how do we get this tendon? All our epimysium, our perimysium, and our endomysium, all these connective tissue, they gradually fuse together and fuse with the periosteum of the bone, the covering of the bone. That structure is called tendon. So tendon is just a collagenous tissue, connective tissue. So let's move on. So origin and insertion, like the way the clinicians remember origin and insertion is anything proximal attachment to the bone is origin, any distal attachment to the bone is insertion. So let's say for the bicep muscle, its origin is from the glenoid, which is from the scapula and the coracoid process, and its insertion is in the radius proximal radius in the little bony prominence, which is what we call radial tubercle, radial tube. So that is the origin and insertion. It doesn't matter whatever way they move, but in anatomy, it is slightly different, origin and insertion. And this is what we talk about the biceps, distal bicep tendon rupture. This is distal bicep tendon is stay attached, so you can see the broad bulk of the bicep, and this is the no more distal attachment, the bicep muscle curl up and being pulled to the origin, and therefore you can see a little bump, which is what we call Popeye sign. Yeah, for this is just for the, and yes, don't forget, these, or if you look at the sarcomere, which is sarcomere is a structure between two Z, one Z and the other Z, and M line in the center. This is the M line, one Z here, other Z here. You can see the actin and myosin. Actin, active A, which is small and thin actin, and myosin, M, big fat M. So M is in the center, in the middle, which is big fat myosin. And don't forget, myosin doesn't get attached to the Z disc. It will go and attach only via the titin protein, which is elastic filament. And why do we get M line? The reason we get M line is at that point, all the myosin, they are interconnecting to each other. And I'm not going to bore you with, this I band, A band. I believe it is pretty boring. And you might feel like, hey, it is too much. So don't forget all the myofibrils, they are wrapped with the sarcolemma and endomysium. Yeah. So I'm going to leave this, but I just want you to remember this muscle contraction. So this is the blue thin actin filament, and this is myosin, big fat actin and myosin here, just trying to enlarge it. And myosin has little beads, which is called myosin head. And there will be a site on the actin where myosin head needs to go and attach. Where is it? Yeah, so this is a good diagram. So myosin head, this is actin. Actin have a site where the myosin head wants to go and attach. That is what we call myosin binding site. And they are usually covered with tropomyosin. Tropomyosin, which is the green structure, which is covering the myosin binding site on the actin. And there is an associated structure which is called troponin. When there is a calcium coming into this actin and myosin, that calcium will go and bind to troponin. So calcium and troponin combination, it makes the conformation changes on the tropomyosin. And because of the conformation changes, the shape change from spiral structure to a straight structure, and it exposes the myosin binding site on the actin, and only then the myosin head can come and attach. That is the contraction of a sarcomere. So this is the relaxation. This is the relaxation And this is the contraction. And don't forget this motor unit. Motor unit is the motor neuron, one single motor neuron, and the muscle fibers it supplies. So this, muscle topic is very, very awkward for me. I do not like it, but I have to learn it. And I will forget about that after this. So please do. So this is the joining site between the terminal button and the muscle. Yeah, this is what's happening. Acetylcholine. Don't forget acetylcholine, which is released from the terminal nerve endings. It will come in, interact with the acetylcholine receptor, and it will cause the muscle contraction. Few little websites which are really good. I want you to try this. There are types of muscle fibers, depending on how they make energy and depending on how fast they contract. Depending on the energy, if they use oxygen, oxidative fibers. If they use glycolysis, glycolytic fibers. Fast and slow fibers, slow contracting is the muscle we talk about in the back, trapezius and latissimus dorsi, because as long as we are upright, it doesn't matter whether we are sitting or we are standing. If we are upright, these muscles in the back, they have to contract for the whole day, all day long. So these are the slow oxidative fibers. So the slow oxidative fibers they use oxygen. They need to have lots of mitochondria. Only then they generate a lot of energy. So they need a lot of oxygen, means they need a lot of blood supply, which means they have a lot of capillaries. And they have a pigment called myoglobin. They are fatigue resistant, like the muscles in the back, trapezius, and the latissimus dorsi. They are thin fiber and they are slow to contract. Like you cannot contract and relax with the back muscle like this. So what about the fast oxidative fibers? So the name, the fast, means they are fast contract. Oxidative, which means they are going to use oxygen. So fast oxidative fiber, they use oxygen. Because of oxygen, they need a lot of mitochondria. They have lots of capillaries. They have lots of myoglobins. They can be fatigue resistant, but not as much as low oxidative. So their muscle size are intermediate. So where do we use fast oxidative? They have to be fast, they have to be oxidative. So our lower limb muscle fibers, like we can run a lot, very fast. We can run for a long distance, but these muscles are not as durable as the slow oxidative all day. So fast glycolytic, so they will use the glycolysis process. They will not use oxygen. So they don't need mitochondria. They don't need a lot of blood supply. They don't need they don't have myoglobin. And they are pale and looking fast contracting, fatigue easily. So the upper limb muscles, like we cannot do this for more than 10 minutes. These muscles will get tired. Sarcopenia, don't forget sarcopenia. Look at the vein here, it's tortuous here. With the muscle contraction, it can move. Of course, it is the vein which is attached to the skin is moving, and therefore the vein moves. So that was what we talk about for the muscle. I know it is pretty boring subject, the muscle. Skeleton, I will go to skeleton homework rather than I believe many of you have done the skeleton homework. So this question, I got it from my colleague who is teaching anatomy, and that instructor is also from Solano Community College. I got this one from that instructor. Why do I put this? I want you to remember the details of some instructors' teaching. So if you look at that, what is this bone? Of course, this is clavicle, collarbone. We all know that. And it is asking, identify the bone and the process pointed by arrow. So this is pretty much detailed. You know, sometimes, yes, we just go pretty deep in. And this little process is called conoid tubercle. So yes, you know, some instructor will ask a few details about anatomy on the bone, the conoid process, clavicle. So, hey, this is easy. How many vertebrae do we have? 5 lumbar vertebrae. Yeah. How many lumbar vertebrae do we have? 5. And if I mention this is sacrum, this is lumbar 5, lumbar 4. So this is the L4, lumbar 4 vertebra. That was the question. So it is a little bit more than like, it is more like applied anatomy. Applied anatomy. So what we need to know is, we need to know there are 5 lumbar vertebrae in human body. And if this is the sacrum, this should be lumbar 5 and this should be lumbar 4. And spinous process, I'm not going to this is the vertebral body. Anything coming out from the vertebral body is pedicle. And joining again each other is lamina. And this is the spinous process. And this is going outwards, transverse, and therefore this is the transverse process. So that's the different. So A is for pedicle, P-E-D-I-C-L-E, pedicle, and C is for lamina. So 2 pedicles come out from the vertebral body and they join, 2 pedicles, they join. That bone, part of the bone is called lamina, L-A-M-I-N-A, and they form the spinous process. Anything going transversely is transverse process. Again, what is structure B? That is anterior superior iliac spine. So this is the, look at that, let's look at that. This is our human pelvis, our vertebral body, vertebral, and becomes sacrum. And on each side, we have the pelvic part of the pelvic bone, which is what we call ilium, I-L-I-U-M. This is the ilium bone. At the anterior point, if we feel on our body, we all can feel this bony prominence, which is very, very prominent. And that is what we call anterior superior iliac spine. Anterior, because it is in the front of the body. If it is in the back here, we will say posterior. And we have this bony prominence here. This is one here and another one bony prominence here. So it will be very difficult to feed this one. It is so much easy to feed this. So that's why this part, it is in the anterior part of the body, and it is not inferior, it is above, so it is superior. So this bony prominence is called anterior superior, because this bone, the whole bone is called ilium, and therefore this bony prominence is called anterior superior iliac spine. And this is the hip joint. So that is the, again, like this is, I love this question because how many vertebrae do we have for this, for the neck, cervical spine? We have 7 vertebrae. So if I say this is the first thoracic vertebra, and what this could be the 7th cervical vertebra. So it is easy, but we have to have the information, like a cervical spine has 7 vertebral body. So if this is one, the last one of the cervical vertebra is C7. So these digits, so simple, isn't it? This is the bones for the hands. This is metacarpal and phalanx, proximal phalanx, middle phalanx, and distal phalanx. That's too easy for you guys. So this is a knee joint, right knee and left knee. This bone is fibula, F-I-B-U-L-A. This bone is tibia, and this is femur, and this bone is what we call patella, which is we call kneecap. Yeah, kneecap is patella, P-A-T-E-L-L-A. And this bony prominence in the front of the proximal tibia is we call tibia tuberosity. Yes, some people, they do have very prominent tibia tuberosity. Some are just normal. So that's C, structure C is tibia tuberosity. And don't forget the patella. Patella is kneecap. Hey, this ankle joint, I just put it in because I know I haven't teach about that. So if you guys go flip Google, I think you will see. So this is the ankle joint, right side. We are looking from the front. And this is the tibia. Tibia is on the medial, and the small bone fibula is on the lateral. The tip of the distal fibula tip is called lateral malleolus. It is on the lateral side. This is on the lateral side. This is on the medial side. So this is the lateral malleolus. And of course, the bony band from the tibia, which is on the medial side of the ankle, is medial malleolus. So usually we would describe it as medial malleolus and lateral malleolus rather than distal fibula or distal tibia. So yes, medial malleolus, lateral malleolus, in between 2 malleoli, malleoli is in plural. In between 2 malleoli, we have the bone in the center, which is the talus, T-A-L-U-S, talus. So this forms the ankle joint. So in between the tibia and fibula, which lateral malleolus and medial malleolus, this bone in the center is called talus. So yes, this is the, if you look at this X-ray, I want you to understand this is the X-ray of the shoulder. Why can we say X-ray of the shoulder? Because you can see a long bone, and it is creating a ball and socket joint in a long bone, and you can see some ribs here, and this is the acromion, clavicle, and this is the plain radiograph of the shoulder. And the catch was which part of the bone. We know that epiphysis, metaphysis, and diaphysis. This is the metaphysia or proximal humerus. It is not in the epiphysis, in the joint articular surface. It is not in the shaft of the long bone, diaphysis. It is not in the diaphysis. It is in the flare, which is what we call metaphysis. And this is the diaphysis. So that is a difference between diaphysia fracture of a long bone and the metaphysia fracture, which is, in other words, we call proximal humerus. So in anatomy again, this is the metaphysia fracture, and this is the diaphysia fracture. And this is the, hey, I see some students who answer just the fracture of the ulna, and the fracture is like both radius and ulna, it is in the diaphysis. So read the answer, read the, what do you call that? The given choice carefully, because some answers are partially correct and some answers are completely correct. So if you have to choose the answer between partially correct answer and completely correct answer, you have to choose the completely correct answer. That is the nature of the multiple choice question. So you are going to have to, you will have to do a lots and lots of multiple choice question exams, and just be careful. If you see something that is correct, there could be another answer which is more correct, which is completely correct. This is the diaphysia fracture of the femur. Of course, why do we say femur? This is the pelvic bone, which we have seen that already. That is the pubic symphysis. And diaphysis, so midshaft is called diaphysis. Scaphoid, don't forget scaphoid bone. We know that we have 8 bones, which is arranged in 2 rows, 4 bones, 2 rows in our wrist. Scaphoid, which is this scaphoid, which is a boat shape, lunate, trichitrum, trapezium, and the pisiform bone, trapezium, trapezoid. Scaphoid, lunate, trichitrum, pisiform, trapezium, trapezoid, capitate, look like a head here, capitis, the head, capitate, and hamate with a little hook here, which is the overlap of the head of the capitate. So scaphoid, she looks too proud, try to, so there are 3 T's, trapezium, trapezoid in the distal row, trichitrum in the proximal row. That is the wrist, distal radius, distal ulna, metacarpal. So I believe you guys know the plane radiograph of a wrist. So this wasn't very difficult. Of course, I put a few little things which I didn't talk about. Skeleton, and then where is it? Endocrine system. Growth hormone, yeah. If you have too much growth hormone, you will be a gigantism. If you do not have any growth hormone, you will be very small, which they call dwarfism. And this is lady. This lady is a normal person. Glands. Don't forget glands. Glands are a group of epithelial cells. So we study about glands when we are doing the epithelial lecture. So glands, if you collect a group of epithelial cells, And if they have a function of secretion and produce fluid, then that is what we call gland. Exocrine gland and endocrine gland. Exocrine gland, the cells make secretion, and that secretion is drained into a duct, which is a system taking all the glandular secretion into somewhere else with the duct, via the ducts. So endocrine gland, they do not have any ducts, so they do not have any formal passage from the cell to the destination. They just secrete hormones and put directly into the body circulation. That is called endocrine gland. And endocrine gland, they do not have any ducts. And exocrine gland, yes, they do have ducts. Hormone is a substance that go to another part of the body, and it's act and on the target site. So hormones could be amino acid based, protein based hormone, or fat based, to make it easy. So if you eat carbohydrate, fat, protein based hormone, and fat based, steroid based hormone. So there are only two hormones. Let's just try to remember that and forget about the rest. And these are the glands in our body. The endocrine glands, pure endocrine, pituitary, pineal, thyroid, parathyroid, adrenal. So how can we remember that? Pituitary is really important. It's in our head. Parathyroid, and thyroid, which is in our neck. Parathyroid and thyroid. And adrenal gland, it is in our tummy. And pineal body is in the brain. So pituitary and pineal body, thyroid and parathyroid, and adrenal in the tummy. So that might need a little bit more repetition, but these are the pure endocrine glands. So what about endocrine plus another function? Hey, hypothalamus. Hypothalamus has nervous function as well as the endocrine function. Thymus has immune function and the endocrine function. Pancreas has called exocrine function as well as endocrine function. Gonads, testicles, ovaries, they do have the sex hormone function and they do have endocrine function. And there are other structures in our body which has some endocrine tissue, like even the heart can produce atrial natriuretic peptide. So when the heart is dilated and stretched, these hormones will come up. It is a good marker for the heart failure. So the A and B come from the heart. So the same thing like gastrointestinal tract has got gastrin, CCK, skin, vitamin D production. So it is more like endocrine function, kidneys, vitamin D, erythropoietin. So these produce hormones which are part of the endocrine. So it's just a broad idea, today's lecture, so that I want you to remember, hey, you have studied this. Don't worry too much about that because everyone forgets. And if we do not forget, we will be great. So we all forget about that. So that's why I'm just trying to repeat a little touch. So how do we stimulate an organ? Humoral stimuli and nervous stimuli. So nervous control, fight and flight thoughts, thinking about that make you hungry, your gastric acid will come out. That is the nervous stimuli. And hormonal stimuli or the humoral stimuli, hormonal stimuli or humoral stimuli. Humoral stimuli mean environment change. Like if there is low glucose, we want more glucose in our body, and there will be glycogenolysis. So if there is low calcium, we have more parathyroid hormone to absorb, to get more calcium in our body. So that's humoral and hormonal stimuli. So your thinking, your like hypothalamus will be secreting hormone to stimulate. So these are the controls of the endocrine system. That is, these are the examples. I'm not going in detail. This is a giant feedback loop. So let's say the hypothalamus will secrete gonadotropin releasing hormone. It is a releasing hormone. Go to pituitary because it is gonadotropin. So the pituitary will release LH, luteinizing hormone, and FSH, follicular stimulating hormone. They will go to the ovary and testes. Ovary will secrete estrogen, testes will secrete testosterone. Once we have enough testosterone or estrogen level in our body, it will come back to the hypothalamus and ask them to stop producing GnRH or LH-FSH. That is the negative feedback. If we have low estrogen and low testosterone, it will go and stimulate the hypothalamus and pituitary to secrete these stimulating hormone. That is the positive feedback. So we have always positive and negative feedback in our body. If we have enough, we go back to the hypothalamus and stop it. That is negative feedback. If we have low level estrogen or testosterone, it will go through the hypothalamus and stimulate this. That is the positive feedback. Pituitary gland, where is it? It's in the sella tessica. Don't forget sella tessica. Anterior pituitary and posterior pituitary. Anterior pituitary hormones are, where are they? Pituitary hormones. Okay, where is this? So anterior pituitary and posterior pituitary, the hormones for the anterior pituitary, the hormone from the posterior pituitary, hormone from the posterior pituitary is easy because there are only two hormones from the posterior pituitary. Because they are oxytocin and the antidiuretic hormone. Oxytocin is for smooth muscle contraction. For the lactating mother, if the oxytocin arises, there will be contraction of smooth muscle that will proper milk out of the breast so that it can feed the baby. For the uterine smooth muscle contraction, this oxytocin will contract, so it helps with the uterus involution. Antidiuretic hormone, the name said anti, against, diuretic, so it will absorb water from the kidney. Anterior pituitary hormones like thyroid stimulates TSH, LH, FSH. So there are quite a few anterior pituitary hormone which we have to. Thyroid stimulating hormone, adreno-ACTH, adrenocortico, follicular, LH and FSH, growth hormone, and prolactin, which makes breast milk. And oxytocin, the posterior pituitary hormone, squeeze the milk out of the breast. So these are the two different things. Prolactin is for formation of milk, and oxytocin is for squeezing the milk out of the breast. Posterior pituitary hormone, oxytocin, and the ADH. So yes, thyroid, pituitary, thyroid gland. We have one right lobe and left lobe connected to each other in the middle with the isthmus portion of the thyroid. And in the thyroid gland, we have follicular cell and parafollicular cell. Yeah, follicular cell will make thyroid hormone, and parafollicular cell will secrete calcitonin. Hey, this calcitonin, what is it going to do? Calci means calcium, tonin means tonic. Tonic means make it more. But it doesn't make the more calcium in the blood, it makes calcium more in the bone. So if you have a lot of calcitonin, which is secreted from parafollicular cell, we will take blood calcium from the blood into the bone. Calcitonin, calcitonic, calcium tonic. It enriches the bone with the calcium. That is what we call calcitonin. It does not take more calcium into the blood. It is not for the blood, it is for the bone, calcitonin. So this is the thyroid gland anatomy. This is the hyperthyroid, the grave disease. Look at the eye, black. You can see the conjunctiva around the eye. Look at that, the conjunctiva, the white structure is exposed. Usually in any normal human beings, if this black need to be covered with either upper eyelid or lower eyelid. In this lady, the eyes, the black color is not covered with the eyelid, both upper and lower pole. What does it mean? Because the eye is pushing for being pushed forwards and eyelids are retracting. Therefore, there is an overexposure. This is the thyroid eye disease, exophthalmos. So don't forget the typical features of hyperthyroidism, and don't forget the features of hypothyroidism. Yeah, so look at the baby, looks very floppy, the tongue is protruding, large and protruding out of the mouth, very sleepy, and look very floppy. And again, don't forget the difference between the goiter and hypothyroid or hyperthyroid. Yeah, goiter means it is an enlarged thyroid gland. That is goiter. It has nothing to do with the thyroid function. A goiter can have normal thyroid function. A goiter can have low thyroid function, and a goiter can have high thyroid function. So a goiter, which is the enlargement of the thyroid gland, has nothing to do with its function. So this is a goiter. I'm not sure this lady has got normal thyroid function, decreased thyroid function, or increased thyroid function. So we don't know the function, we just know the size. A goiter is the enlargement of the thyroid gland. Parathyroid glands. So as you know, parathyroid glands are small little peanut-sized glands which are stacked on the posterior surface of the thyroid. And there are two pairs in general, like two superior and two inferior. But they can be like 4, 5, 6, 7, 8 might be. But generally there are 4 parathyroid glands, 2 on the right side, 2 on the left side. And parathyroid gland have parathyroid cells. Parathyroid cells produce parathyroid hormone. Parathyroid hormone increase the calcium in the blood. So parathyroid hormone and calcitonics, they are opposite. Parathyroid hormone will take calcium from bone into the blood. The calcitonin will take calcium into the bone, makes the bone full with calcium. That's why calcitonin, they enrich the bone with calcium. So calcitonin comes from the parafollicular cell, C cell, from thyroid gland. Parathyroid gland, parathyroid hormone as parathyroid hormone for calcium enrichment. So look at that parathyroid hormone, parathyroid glands, which are 2 on the right and two on the left and 2 on the right, superior and inferior. So they are very small. So when we do thyroid surgery, we have to be very careful. Sometimes, you know, without knowing, we can take the thyroid gland and we can also take the parathyroid gland, which means they will get hypocalcemia. low calcium. Thymus gland behind the sternum produce T cell. It is for immune system. Gonads and ovaries we have to study later in detail in the reproductive system. Interstitial cell will produce androgen. Ovarian follicular cell will produce estrogen. Pineal body, that's for your sleep and wake pattern. Don't forget little calcium in the pineal body, which can be seen as brain sand. So usually not. If you take an X-ray for the brain, you are not going to see this. It is too much detail. And it is related to melatonin, which is wake and sleep cycle. Pancreas, don't forget pancreas. It is a big gland, and it is both exocrine and endocrine gland. Look at the pancreatic duct. So that way contribute to the exocrine pancreas, and there will be endocrine pancreas where there is insulin, glucagon. These are the endocrine portion of the pancreas. Insulin will go directly into the blood vessel. Glucagon will go directly into the blood vessel. That is the endocrine portion of the pancreas. And those pancreatic cells which secrete bicarbonate, they go along the duct, pancreatic duct, and that is the exocrine function of the pancreas. So alpha cell will secrete glucagon, beta cell, insulin, delta cell, somatostatin. Exocrine gland, sinus cell, and ducts, so bicarb, digestive juice. Cushing syndrome, look at that. Excessive steroid in the body, and this lady has got a hump, which is because of the excessive steroid, and there is a fat deposition. And she looks slim here, and she looks fat because she is getting Cushing syndrome, the same lady before and after treatment. So adrenal gland has got 2 layers. Oh, it's 1 hour now. Let's move on. Yeah, I hope you can. We'll keep going for like another 30 minutes. Adrenal gland has got adrenal cortex and adrenal medulla. Adrenal cortex has 3 layers: GFR, zona glomerulosa, fasciculata, and reticularis. And adrenal medulla is medulla in the center. Adrenal medulla will produce epinephrine, norepinephrine. And adrenal cortex has 3 layers. So 3 layers will secrete 3 different hormones. GFR, from outside to inwards, glomerulosa, fasciculata, and reticularis. Yeah, zona glomerulosa will produce mineralocorticoids, oxymos. Fasciculata will produce glucocorticoids, so steroid hormone, and zona reticularis, DHEA, dihydroepiandrosterol, so which is the sex hormone. So the way we try to remember from outside to inwards, the deeper you get in, the sweeter it gets. From its salty mineralocorticoids, aldosterone, salty, salt and water retention. Glucocorticoids, steroids is okay, and sex hormone, sweetest here inside. And of course, adrenal medulla has only 1 layer, which is produced norepinephrine and epinephrine in the medulla. So adrenal glands sit on top of the kidney, upper pole of the kidney, and it is like a pyramidal shape, or in 2-dimensional. It is like a, triangular shape. Adrenal gland, in other words, suprarenal gland, because it is on top of the kidney, suprarenal gland. So adrenal glands here. Okay, so that's the endocrine system. The heart. Let's go to the heart. The heart lecture, I will go to the homework for the heart. So yes, this is easy. So the heart, epicardium, endocardium, which is the inner lining of the heart, which is made of just simple squamous epithelium. But of course, it is in the heart. So we have to give it a different name, which is what we call endocardium. Endocardium and the muscle layer is myocardium. And the outermost layer is pericardium. Pericardium has two layers. So this is one layer, pericardium, and this is the another layer. So let's look at the options. The question is, the epicardium is the same as. So viscera of the serous pericardium. Okay. So viscera, pericardium, and this is the outermost is the fibrous pericardium. Look at the structure, which is very hard taut structure. This is the fibrous pericardium, and this is the serous pericardium. So serous pericardium has got two layers. Serous pericardium, which line the fibrous pericardium, is called parietal, and serous pericardium, which covers the heart, is called visceral layer of the serous pericardium. And this is also called epicardium. So endocardium, myocardium, epicardium. Epicardium is nothing more than the serous pericardium, which is on the visceral surface. So that is the, I believe you all know this diagram. The heart, the right atrium makes the right border of the heart. Right ventricle makes the anterior surface of the heart, and left ventricle makes the apex portion of the heart and inferior surface of the heart. And left atrium, we can only see the very small portion because it makes the most posterior surface of the heart. And the big aorta come up from the left ventricle. And from the aorta, there are three main branches. On the right, brachiocephalic. This brachiocephalic will later divide into common carotid and subclavian for the right side. And the common carotid for the left, common and left subclavian for the left. So these two on the right, they start as a common pathway and finally we divide. On the left, they start separate. And look at the artery, look at the sulcus, which is a depression here, which is going around the head like a crown, and therefore we name it coronary sulcus. In the right coronary sulcus, we have right coronary artery. In the left coronary sulcus, we got left coronary artery, which quickly divides into anterior descending, in between the ventricle, anterior interventricular artery, and which go loop back and therefore circumflex, turning around. The circulation inside the heart, the right atrium, we accept all the blood from the whole body via superior and inferior vena cava. That from atria, right atrial blood, we go through the tricuspid valve into the right ventricle. From the right ventricle, we go through the pulmonary valve into the pulmonary trunk and divide into right pulmonary artery and left pulmonary artery. These are the arteries because they are arising from the heart, although they are carrying deoxygenated blood. These arteries will divide and divide in the lungs and finally become small capillaries, and we get gas exchange. We take the oxygen from the lungs back to the heart and come back to the heart. Although they are carrying oxygenated blood, they are coming into the heart, and therefore their name is pulmonary veins. They will go into the left atrium through the mitral valve into the left ventricle, will be pumped up through the aortic valve into the aortic arch. So that's like we have repeated this again and again, so which should not be too difficult for you guys. Hey, right border of the heart, right atrium, apex of the heart, left ventricle, inferior border of the heart, left ventricle, anterior surface of the heart, right ventricle. Everything is easy now. And this, like fibrous pericardium and serous pericardium, is a little bit twisty. Be careful. Fibrous pericardium is like the trainer boots you are wearing. So it is hard and fibrous and keep everything in order. And the serous pericardium is like our socks, like make it smooth and nice. And serous pericardium, it's full. And one part of the serous pericardium covering the heart is called visceral serous pericardium, and the other fold of the serous pericardium covering the fibrous is called parietal. This is called the epicardium, endocardium, myocardium, and epicardium. So these are the structures you need. So these are the pictures, which come back again and again. I hope that will make you remember which structure is what. And here I have put this question. Tell me 5 facts that you know about the heart. So what I want is, I want you to be a little bit descriptive. Descriptive means like if one of your friend or one of your colleague asks you, hey, what is a heart? Hey, what is a lung? Hey, what is a bone? So these are the random questions being asked by those people who doesn't know anatomy or who might be studying arts. And then they are saying like, hey, I don't know, what do you mean by bone? What is a bone? What is a muscle? So like, I want you to tell, you should be able to tell a few little things. Like, hey, a heart, it is in the mediastinum. Like it has got right side of the heart, left side of the heart. It has got 4 chambers. The major blood vessel come out from the heart. The heart is the size of the ventricles are different. There is a difference between atrium and ventricle. So I just want you to be a little bit descriptive or a little bit talkative about what you know. So that might stimulate for everything in your life. Like whenever you go to an interview, like the almost every question you get asked is, hey, tell me about yourself. That is the interview question, the very beginning. So I want you to be a little bit descriptive, like so that so anatomy, like whatever we do here, we should be able to describe at least ourselves. And so that's why I just put that question. Nearly finished, guys. Just put that with me for another 15 minutes and I will let you go. Just sit back and relax and listen, why we have to study all these. And blood vessel lectures. Hey, I never teach you this. This is the cycle of Willis. This is what we call cycle of Willis. It's in the brain. It is the way blood finally get distributed in the brain. So I want you to look at that. Just here is the link as well, describing about the cycle of Lewis. It is a cycle like all three major vessels. This is the vertebral artery, so which is inside the cervical vertebra. These two vertebral artery from right and left, we combine and they become basilar artery. This is the internal carotid artery from the left, internal carotid artery from the right, and then they will just connect to each other. Look at the way it becomes like a cycle. So that is the way the blood gets distributed inside the brain. So that is the arterial communication. Where is it? Oh yeah, so this is easy for you if you just flip the diagram. But the layers of the arteries or the vein, tunica intima, media adventitia, that's the basic. Intima innermost, what is it made of? It is made of flat squamous cell. The same thing like it is lining the heart. The heart is inside the heart, it is lined with the flat squamous cell, but we need to make it a little bit more impressive. We said endocardium. So in the blood vessel, we said endothelium. The same. Endocardium, endothelium, no big difference. They are nothing more than the simple flat cells, squamous epithelium. And after the endothelium, we have tunica intima media, tunica media means middle muscle, and tunica adventitia, which is the outermost layer. And of course, life is not that simple. There could be a little bit more if we want to be a little bit more specific. So in a bigger vessel, tunica media will be sandwiched by the inner elastic membrane and outer elastic membrane. And in a bigger vessel, under the endothelium, we have the subendothelial layer. So it depends on how big the vessel is and what sort of vessel it is. Is it elastic blood vessel or is it the muscular blood vessel? Muscular blood vessel, in the muscle layer, we have a lot of muscle and elastic fibers, we have to sandwich it. But for something like big, large aorta, elastic vessel, they will have a lot of elastic fibers in the tunica media itself. And capillaries, they are like no more, nothing more than the endothelial layer, which is, of course, endothelial layer, it is the flat squamous cell, so they cannot stay on their own. They have to rest on the connective tissue layer, which is called basement membrane. And this is just the capillaries, yeah? They do not have mast cell or adventitia. And therefore, their job is to diffusion and transpose across the membrane. Hey, don't forget this celiac trunk, superior mesenteric and inferior mesenteric. I hope the blood vessel lecture was interesting.
I had a question about the mesenteric arteries. Could you review those?
Mesenteric arteries, yeah?
Yeah.
Yeah. So I think I will go to the lecture slide for that. Where is it? Modules. Blood vessels, anatomy of blood vessels. So, yeah. So this is what we talk about, the blood vessels. You know, this is the heart. We have 4 chambers, and the big vessel coming out from the heart is called aorta. Look at the way it goes. It goes up and it's arch and it's come down. So that's why we say going up, ascending aorta, arch of aorta, and descending, coming down, descending aorta. And it will continue in the thorax because the heart is in the thoracic cavity. Therefore, we will call it thoracic aorta. And it has to perforate through the diaphragm, come into the tummy. So once it is in the tummy, it is called abdominal aorta. Abdominal aorta. And remember, like paired artery means on the right side, right side and left side, right side and left side. So in the abdominal aorta, so this is paired arteries are renal arteries for the kidney. So for the right kidney and left kidney, they are very, very much perpendicular, arising from the abdominal aorta, and slightly oblique paired artery, which are gonadal arteries, like right ovary or testicular artery, left ovary or testicular artery, and finally aorta we divide into right common iliac and left common iliac. So these are the paired arteries. So this is in the abdominal aorta. If we look at the abdominal aorta again, like these are the paired artery, renal artery, which you have seen, the testicular artery and ovarian artery, right and left paired artery, which we have seen. And there are unpaired, only single coming directly in front of the aorta, like one here, another one here, and another one here. So just immediately passing through the diaphragm, the thoracic aorta pass through the diaphragm and become abdominal aorta. It gives us a very big branch just in front of it, coming out like that. That is what we call celiac artery. And it goes down a bit and another big artery come out from the in front of the aorta. It is just one and single. That is called superior mesenteric artery. And it will give branch pair artery like renal artery. It will give pair artery like testicular or ovarian artery. And just before it divides, it gives another big single branch in front of the abdominal aorta. it is called inferior mesenteric artery. Of course, celiac artery, superior mesenteric artery, and inferior mesenteric artery. So I'm just going to find these arteries here. We have the diagram there. So look at that, yeah? This is the diaphragm. So on the upper part of the diaphragm, it is thoracic cavity. We are now looking into the abdominal cavity. And look at that, aorta. Aorta is passing through the diaphragm. And when it passes, it gives us a big branch, like just one single big thick artery. That is what we call celiac trunk. Trunk means it is a big one. And this celiac trunk will branch into a artery which will go and supply the liver. That is, we'll call it hepatic artery. It will go to the stomach, coming out from the stomach, gastric artery, and it will go to the spleen, splenic artery. So look at the size of this celiac trunk. It just, once it perforates the diaphragm, it just becomes a big branch, give to the every important structures in the upper abdomen. So yes, of course, you know, from our knowledge, 9 regions of the abdomen, right? Hypochondrium, we have liver. So every structure in the upper portion of the abdomen, this celiac trunk will give blood supply. So on the right side, it goes to the liver. Hey, in the left side, we have spleen on the left hypochondrium. So this vessel will go to the left hypochondrium to supply the spleen. And in the center, epigastrium, we have the stomach. So it gives blood supply to the spleen. So it gives every structure in the upper part of the gastrointestinal tract. So that is the celiac artery, celiac trunk. Look at the another one. We have, hey, look at that, this one. Okay, I will come back to this one. Hey, look at that, look at this, it's lovely. So celiac trunk is here, and second branch and paired, it is not right and left, it is only one come from in front of the aorta, rising from the front of the aorta. That is the superior mesenteric artery. So it will give supply to the mesentery. Mesentery is the structure which connects the colon attached to the back of the body, and it gives the supply to the small intestine. Yes, superior mesenteric artery gives small intestine, large intestine like the cecum, ascending colon, and transverse colon, up to the junction of the right 2/3 and left 1/3. So that is the job. So which means like celiac, superior mesenteric, and inferior mesenteric, they are giving all the internal organs, internal viscera for the abdomen, isn't it? If we think like that. So upper portion is giving the everything in the upper part of the abdomen. Middle, second portion, superior mesenteric, giving the every part of the intestine in the upper part. And look at the inferior mesenteric here. Inferior mesenteric coming out just before it divides into right iliac, right common iliac, and left common iliac. It gives inferior mesenteric. We give blood supply to the lower part of the large colon, like sigmoid colon, descending colon, and left 1/3 of the transverse colon. Look at that. So that is very beautifully arranged. Superior celiac trunk, superior mesenteric, and inferior mesenteric. So it will, these single and paired branch of the aorta will give all the viscera. And if we look at the previous diagram, look at that, celiac, and now we can see the renal artery, which is very much like perpendicular to the abdominal aorta. So renal artery, look at that, renal artery, and testicular artery or gonadal artery. Here, the left gonadal artery and right gonadal artery, they are paired branch. So don't go everything in too much detail, but I want you to have a little bird eye picture, like, oh, yeah. So these are the arteries. And of course, common iliac, we give a internal iliac into the pelvis and we continue as an external iliac, and that will become femoral artery, which we can feel in our groin. So that is about the blood vessels, and blood vessels. And so finally, we're going to talk about the blood. So blood is easy. I think blood is too simple for you guys. So how much blood do we have? We have 70 ml per kg. Yeah, don't forget 70 ml per kg. So if you are 100 kg, we will have 7 liters. If you are 70 kg, you will have 5 liters of blood in our body. It is a connective tissue, specialized connective tissue, which is made of cell and matrix. Matrix is fluid matrix, which is what we call plasma. And cells we have in the blood, we have red blood cell, white blood cell, and platelets. So let's look at the fluid portion, plasma. We will, of course, it's fluid, so there will be lots of water, electrolyte like sodium, potassium, chloride, calcium, everything we say. Nutrients, glucose, carbohydrate, fat, protein, like glucose, lipids, amino acids, vitamins, waste products, urea, amino acid, hormone, antibody, clotting factors in the name of fibrinogen, globulin for albumin for oncotic pressure. So the serum, what's the difference between serum and the plasma? If you take fibrinogen out of the plasma, you will get serum. So serum is equal to plasma minus clotting factors. So fibrinogen is a clotting factor. So if you take out all the clotting factors, you will get serum. Take somebody's blood, put it in the test tube, centrifuge it. We split cell and we are splitting cell and the fluid. The cell makes 45% and the fluid portion makes 55%. The nearly 45% of that 45% is RBC. The WBC and platelets might be about 1 or less than 1%, So of course, if we look at the blood film, we are going to, then hematocrit, we all know that. If we take a blood, draw a slide, and look under the microscope, of course, we are going to see a lot of red blood cell. Why do we see red blood cell? Because RBC, red blood cell, erythrocyte, which makes the 45% or might be 44% of that 45% of the cells. And you will see WBC. So the way we try to remember is never let monkey eat banana. So neutrophil, most common. Therefore, we see 2 neutrophils. Let lymphocyte, here lymphocyte. Monkey, monocyte. Eat eosinophil. Banana, basophil. We don't even see because basophil contributes less than 1%, less than 1% of the cell. And therefore, it's not surprising if we do not see basophil. So if you want to make a bet, you have to put bet on the neutrophil, isn't it? Because neutrophil makes about 40 to 60% of the white blood cells. So you are going to see lots and lots of neutrophils. This is the blood film, a lot of lymphocyte here. Hey, it is called lymphocytosis, which could be lymphocytic leukemia, or it could be just like overwhelming infection. Hey, what are you seeing? You are seeing the target cell. So that is the red blood cell problem. The little target, that's the target supermarket we go. So these are the target cells. We do have target cells in the blood as well. Look at the shape. RBC shape is biconcave, like a donut ring. WBC shape is spherical. Platelets is like a disc, plate, I mean little dish plate, broken piece of dish cells. And RBC, WBC, and platelets. And so, yes, so if you look at the cell, erythrocyte, leukocyte, and platelets. Leukocyte, white blood cell, neutrophil, 50 to 70. Never lets monkey eat banana. Yeah, never lets monkey eat banana. Neutrophil, like might be 3 lobes, might be 4 lobes, might be even 5 lobes. The cytoplasm is pink. The nucleus is dark purple. Eosinophil cytoplasm is pink. It is bilobed, only 2 lobes, like an ET or like somebody wearing sunglasses. So ET, eosinophil. Basophil, you're not going to see much. There is not much character in it. Lymphocyte, the blue cytoplasm, the nucleus is really big, and it is like nearly completely filling the cytoplasm. And the monocyte, the nucleus is kidney bean, and its cytoplasm is purple, yeah, blue purple. So that is the difference between the granulocyte and agranulocyte. Granulocyte cytoplasm is pink, agranulocyte cytoplasm is blue. So that is easy for you guys. And the job, we come and study this again when we have to do immunology. And the platelets, yeah, platelet, little like a pancake plate, little plates. It's just nothing more than a fragmented cell. It is not a really cell. And the way it go and plug. So look at that, platelets is entrapped in the fibrin network. Bone marrow, red marrow, and yellow marrow. Most of our bone marrows at our age, we are full of fat and yellow marrow. When we are baby, we have lots and lots of red marrow, but even in the adults, we have red marrows in the pelvic bone, in the pelvic ilium, and in the vertebra. Yeah. So in the vertebra, we have red marrow. In the pelvis, we have the origin of the red blood cell. So only the lymphocyte, T lymphocyte, B lymphocyte, they arrive from lymphoid stem cell. The rest will come from myeloid stem cell. That is the difference between lymphocytic leukemia and myeloid leukemia. So we'll not go there yet, but lymphocytic leukemia, I believe you have heard of it, and myelocytic leukemia. So lymphocytic leukemia, they originate from the lymphoid stem cell. Myelocytic leukemia, they originate from the myeloid stem cell. So basic cell, don't forget that the shape of the RBC is biconcave and circular structure. They can change shape, dip and turn around in a small little capillaries. But in those patients with sickle cell disease, the cells, they just change the shape into sickle shape when there is lack of oxygen. If there is no enough oxygen, their cell will change into sickle shape. That is what we call sickle cell disease. So yeah, I hope not. It is not too boring for you guys. But what I want is, like, I just want to refresh your memory and just try to give you some like reminder that, hey, you have done all these already. So don't underestimate yourself. You have done quite a lot already. Have you got any questions? Are you stay there?
Professor, when is I don't know if you already went through this, but when can we take the first the exam? Is it already open?
You mean the very first one, Introduction to Anatomy, or this?
No, the one for September, is that one already open?
Oh, it's not open yet. It's not open yet. September. So end of September exam not open yet. So what I plan to do is, so you guys do not have any homeworks for today, which is good. You can catch up with the previous lectures. And we were on Wednesday and Friday, we do respiratory system. So the respiratory, so one topic we are spreading on 2 days. So which will be a little bit easier for you guys. And you will only get the homework, only one homework for the respiratory. So you will have time to go back and look at all these homeworks from the previous lectures here. And then I think on next week, Monday, I just wonder it will be a good time to open the exam. What do you think?
Sounds great, Professor.
Yeah. So
you're
just,
saying you would open the exam on Monday and we would have a lecture on Monday?
we were, good question.
Because you give us normally, Professor, you always give us a week. So, I mean, if you opened it on Monday, I mean, that means that we have till Sunday to take the second one, correct?
Yeah, so I mean, for the exam, it will include this skeletal muscle tissue, skeleton, endocrine, heart, blood vessel, blood, and the respiratory system. And of course, skeleton, and including the respiratory system. So the lungs. So I hope that is the whole thoracic cavity, heart, lungs, and the major blood vessels and the blood, and some skeleton. Of course, I don't want to give you new information on the day of the exam.
I was gonna say, I would prefer to attempt the exam on Friday and then redo it Sunday and then start new material Monday. That's what I would do.
Yes. So which means like, yeah, of course, I will open the exam for the whole week. So for those people who want to do over the weekend, you do it, or those people who do not have time, then you can keep doing that for, let's say, about in total 1 week, next week Friday, or not this week Friday, next week Friday, or maybe Saturday, if I give time for those who are a bit busy with other stuff. Yeah, I don't want to give you exam and at the same time, I'm talking a lecture which is not included in the exam.
Yeah, I'd be honest, I'd probably skip the lecture, do the exam, and then go back and listen to your recording.
Yeah, so I can post the exam on Friday for those people, those students who haven't done the homework or who are a bit tight on the weekend, they can do the exam. What do you think, Otto?
I think, Professor, like, I think personally, like, if you gave us from this Friday to next Friday, would be great.
Yeah, we'll do that.
That way, for the people that want to do it like on the weekend,
Yeah,
you can do it, and then for the people that gotta catch up, we still got Monday to Thursday to do it.
Yeah, that's good. Cause Friday, everything calm down. You might be free for the weekend and just take it off from your head. But for any reason, please tell everyone like if because of the reasons, like some students, they have to go because they have family reasons, they have to go away, if one of the relatives not very well, that sort of stuff, or one or two students who have problem, medical issue. So just tell them, everyone, just contact me. I will open the exam anytime when they are ready, because I want you guys to do the exam. I have to